All right, welcome everyone. This is our final live event for World Delirium Awareness Day 2021. This year we really wanted to focus on moving the evidence we have to prevent and reduce the harms associated with delirium into practice. Implementation is extremely challenging work. We have a number of live and pre-recorded sessions on this topic that are available on the iDelirium YouTube channel. In full disclosure, this session is also being recorded and we will upload it to YouTube afterwards and tweet it out. So my name is Heidi Lindroth. My vision is a world without delirium, and I will be your moderator today. I'm a nurse scientist at Mayo Clinic in Rochester, Minnesota, and I recently graduated with a certificate from the Center for Health Innovation and Implementation Science focused on Agile methodologies. Kate Callahan was my co-part, and Malaz Busani is my primary mentor. But I'm really excited to share this different method of implementation with everyone. So the format of this live session is designed to be very informal. And we really wanted to stimulate conversation around changing practice to reduce delirium. So please feel free to raise your hand when you want to speak. Put your questions, comments in the chat box. I'll be your as I said, I'm the moderator. So we'll do our best to have that conversation. So I'm really excited. I'm going to have Lindy, Bilimek from Parkview Health and Kate Callahan introduce themselves. They'll be sharing their experiences today, and we'll go from there. So take it away, Lindy.
Hello, I'm Lindy Bilimek. I'm a geriatric clinical nurse specialist at Parkview Health, predominantly focusing on falls, delirium, and dementia within our organization. Parkview is located in Fort Wayne, Indiana. It's a 12 hospital system serving Northwest Indiana and Northwest Ohio and Northeast Indiana. And I also am a graduate from IU School of Medicine's Innovation and Implementation Science program with Dr. Bustani. And I will let Kate introduce herself.
Thank you for letting me join you, Lindy, Heidi. Hi, everyone. My name is Kate Callahan, and I am a geriatrician and health system scientist here at Wake Forest in Winston-Salem, North Carolina. I have a goal of scalable, sustainable solutions to promote independence for older adults so that our healthcare system can help older adults thrive and not just survive. My work is predominantly in frailty, but of course we know that the brain and body are connected, shockingly enough. And so I'm very interested in how delirium is often more common in those who have frailty, and thinking about how we can develop solutions to reduce the risk of overall functional decline when older adults engage with the healthcare system. So I'll be sharing a little bit of work that I've done in partnership with home critical care physicians and the nursing staff here at Wake Forest, and some of the pitfalls we've had, as well as some of the successes. So thank you.
Okay, I'm going to pull up my screen here.
Oh, I also am, I mean, Heidi said this already, but I'm a graduate of the Malaz School of Making Systems Change, also known as Agile implementation.
Have to have that part, right? All right, are you able to see my screen okay?
Yeah.
All right. So today, as you've heard, we're going to talk about Agile implementation and implementation science. When I first discovered Dr. Bustani's program, it was actually at the annual Delirium meeting, and I was instantly intrigued by the idea of Agile implementation. I had routinely encountered barriers with implementation, let alone implementation in a complex health system as large as ours. So when I heard about implementation science, I was hooked. And when we discuss implementation science, we're looking at that rapid, efficient, and sustainable implementation. A lot of times that sustainability piece, especially from my perspective, is the challenge. We continuously see things rolled out in the healthcare system that we don't continue to monitor, unfortunately. And then with that, we lose that sustainability. And when we're looking at rolling out any of these evidence-based programs or practices in the real world, we're trying to accomplish the quadruple aim. So looking at that, we're looking at improving outcomes, providing better care at a lower cost, and enhancing the experience for the patient. And looking at all these pieces, this is definitely something that comes into play with delirium and delirium-related care. So something to keep in the back of our minds as we're moving forward. I did want to touch on this first before we get started. These are the steps from the AI playbook, so the Agile implementation playbook that we're going to walk through today. As we walk through these, we're going to discuss both Kate and I's experiences with implementation related to delirium programs in the health system. So you'll see these steps throughout the presentation and then again at the end, that way you have them. Before we get into it any further, just to touch on Parkview, we are a not-for-profit community-based health system in Northeast Indiana and Northwest Ohio. As I had said, I was instantly intrigued by the idea of Agile implementation. I had just started working on a delirium project around the time that I met Dr. Bustani. And as you'll hear, delirium is definitely complicated, but the process of implementing practice change in the real world is definitely a complex process. So we're going to walk through some of those steps. I like this slide a lot. I had to put this in here because, as we all know in healthcare, I mean, it's a never-ending dynamic dance. There are so many pieces that come into play in the health system, and a lot of times we tend to all have our own specific focuses, and without that overall picture and that ability to kind of zoom out and then zoom in at the level of the patient, we can forget some of these pieces as we're starting to put together a program. What had led to this? It was a common misconception, unfortunately, among our system, that delirium only impacted our ICU patients. So we had been screening for delirium routinely several years prior to me starting here. I've been here about 6 years, and I could not get across this barrier. I kept hearing it's not important, it's not relative, you know. For some, it doesn't occur outside of the ICU. That's why they call it, you know, intensive care, all the different terms that we have for delirium. We don't tend to see, especially even with encephalopathy, we had that confusion that there's a difference there and those things do not apply to that med-surg patient. So what I set out to do was to make the case to improve our delirium-related care. It's definitely been a challenge throughout this. There's been so many projects that have been started on delirium, I'd say over the last 10 years, with little changes in our outcomes or our behaviors among our workers. As we're all aware, delirium is a disturbance in mental abilities, resulting in confusion and altered awareness over a short period of time that fluctuates, which makes it even more challenging for that bedside nurse to identify and then to share and consistently identify over a period of time. It is preventable in 30 to 40% of cases, but it's misdiagnosed or not recognized in about 60% of cases. And what we found when we were trying to make the case for this is that only about 24% of our patients throughout our health system that were diagnosed with delirium were ever in the ICU. So we had a large portion of patients that were being diagnosed with delirium that were outside of that critical care area. Once we were able to demonstrate that and dive into the increased length of stay, the increased cost associated, and then of course the negative patient outcomes, we were able to make the case to start our work related to delirium. So we confirmed that demand. On a side note, I have to say this for Dr. Bustani's purposes, it's not usually recommended to fix a problem that no one is asking you to fix. But as a CNS, that is kind of the art of our role. We identify a problem, we understand the depth of the problem, identify the best possible solution, and then share that with the stakeholders in a way that nudges them to the desired behavior. It was definitely not an easy task. changing the behaviors and the mindset of these individuals took time, but through some of the components we'll discuss here in a little bit, we were able to get our journey started, and I'm happy to say that it's paid off and continues to do so today. So step 2, we really have to look and identify those evidence-based solutions. So we've confirmed demand. We've ensured that, we were in fact looking at signal, not just the noise. And we had a lot of work that went into place when considering this. For one, we had a lot of teams that were working on Delirium as independent projects with no oversight among those groups. So we knew that we were going to have some challenges, but we also knew that we weren't the only one facing this problem. The CAM ICU was currently being used in our critical care area, so we did have some experience. However, we knew that there was something out there for our med-surg nurses. So we actually challenged them. We put together a team and challenged them to identify what tool they would like to use in their areas to screen for delirium. In doing that, we actually did a thorough literature search and let them trial the scales themselves and come up with the best opportunity. And what I'm happy to say, we've seen this occur. We brought together both the committees. We had a critical care and then a med-surg delirium committee, and we brought in our EPIC builder. And they were able to walk through and ask, what could we do to simplify this? If we add a second screening tool, how do we ensure that the nurses understand this during periods where we have a transition of care, so from the ICU to med-surg or vice versa? And what they came up with was the combination. They selected the BCAM for our verbal patients and the CAM ICU for our nonverbal patients. And what they did is they integrated those into the EMR. That way, for one, the scales spoke the same language, whether you were in critical care or non-critical care. But then also the nurse just had to select, is the patient verbal or nonverbal? And then was able to, that opens the screen and they can complete that. So we didn't have to go to the trouble of creating 2 different sections in our EMR to document this. And I think that was a huge satisfaction piece among our nurses. And then it also helped to kind of guide them as to which scale to use, because we were using that CAM ICU on verbal patients prior to this.
Well, Lindy, you are EPIC shop, correct?
Yes. Yeah, we learned a lot in this journey from the EPIC perspective. We actually, when we looked at the intervention, we're trying to consider, how we could design this in the way that was going to be most feasible for nursing. We also wanted to include those A, B, C, D, E, F components for the ICU area. So while our scale is the same in those different areas, it does drop down and allow for the documentation of those critical care components, such as the SAPs and SBPs.
Hey, Lindy, can I just ask you, where does your screening process start?
Our screening process starts with a baseline mental status.
Okay, so with a newly admitted patient?
Yes.
Okay.
Yes, yeah, they complete it. We do find some challenges. We had developed it to go into our admission navigator. So it's completed at the time of admission, and that's where then they can document the patient's baseline. What we see is that we don't often know the baseline initially. So we did put some specific information in there. That way they understand that this needs to be actual information. If the patient's coming in confused, you're not going to get the baseline from the patient. We also made it so that that baseline would stay in the EMR. That way it's there, and the only time it ever needs to be updated is if that patient has a chronic change. So we put that right at the beginning of the delirium assessment, since feature 1 specifically asked for a change from baseline. And that was definitely helpful, but of course we still run into challenges, especially when it's hard to identify that baseline. But we've taught them to just always, if in doubt, always consider it a change from baseline, and then they have to use their critical thinking as far as how the patient was functioning. If they were driving at home independently prior to this admission and they're now very confused, we know there's been a change without knowing the true baseline. The third step here is developing the evaluation and termination plans. This, I think, was my least favorite part. I don't know about anyone else. I'll just be honest here, but you had to be very honest with yourself and with your team. What does success look like? What does failure look like? How long should this project take? That one was a struggle for sure. And then who gets to make that call to terminate? Time and time again, I've been on projects that just continue and continue and continue with, I mean, we lose direction. I think we lose our overall focus, where this time we sat down and decided what were our metrics going to be, what would constitute success or failure, and then again putting together that task force which was able to terminate the plan if need be. We would see those failure criteria met. The other piece that I think is very challenging up front, you really have to consider your metrics. So you need to know, what are those outcomes that you're looking for, but also where are you getting them? Are they accurate? Are they going to be timely? And I quickly discovered there's not a lot of accuracy, or it wasn't at the time, with regards to our data. We didn't really know what ICD-10 codes that we should be looking at. And we also discovered that we had a huge barrier with recognition of the overlap between delirium and encephalopathy. I don't know if anyone else on here runs into that, but unfortunately, as we know, the DSM calls it delirium, ICD-10 wants to see that encephalopathy, and our physicians are saying, no, it's delirium. And so we had to do a lot of education on that piece related to, the reimbursement and coding it appropriately for the patient severity. So that was a challenge, and I will not forget when I asked to start this project, I was actually told by someone from leadership that delirium and encephalopathy were completely different, and there was no way I could ever do this. But I'm telling you, it's one of those, it became my passion. This was something we needed to do. And that storytelling piece really helped. Malaz was very beneficial in sharing with us how that story can really carry the message. And so what we had done is we had a former employee, unfortunately, who was with us and did end up developing delirium. And this gentleman went on to have long-term problems related to his delirium experience, and unfortunately ended up losing his job because he was not able to retain information. He would get lost when rounding in the hospital. And we were able to speak with him and with his blessing, share that message. And that went a long way with our coworkers because this was one of our own. It happened on our watch, and it unfortunately affected the rest of this gentleman's life. So that was one of those kind of heart-crushing, but definitely carried the message away for us. It also was a good reminder that we have to keep our eyes on the unintended consequences of work like this. So you set out to screen for delirium in more areas. What's going to happen? You're going to see an increase in your delirium cases, potentially an increase in medications or potentially dangerous medications. This gentleman, for example, had received a lot of different medications that now in hindsight, we question, were those the most appropriate? So those are things to consider, as well as your consults. We built an order set that included the consult option, but we didn't want to flood them with consults, especially psych and neuropsych, since this is a medical-based diagnosis. That's what we need to see occur, that medical dive into what is going on with the patient versus that delay in waiting for a consult just to have nursing interventions put in place, such as opening the blinds or getting the patient up the chair for meals. The takeaway from this slide, though, and I love this, it's my tagline, is to fall in love with the problem, not the solution. You fall in love with the solution and right away you're getting yourself in trouble, because the minute you start to own a problem, it becomes very hard to give up. If you let yourself become attached to that solution, you could be very disappointed in the outcome and potentially, not implementing the appropriate measures, because we all become very biased to the work that we've been passionately pursuing for years.
Yeah, I add that, just real quick on that, the termination and the last slide. I really find that is so tied to the first step of demand, because depending on who's on the team and who's involved and the stakeholders and what they're if with their physicians or nurses, like they might have a completely different viewpoint on what the evaluation, like how to evaluate it and what determines failure and if they're okay embracing that failure.
Yes.
This
Yeah.
wound up being a critical piece when we were working through, and Lindy, I'm so enjoying your presentation. I'm just going to wait till you're done, and then I can chime in with some Wake Forest experiences at the end. But just wanted to augment that situation and echo the falling in love with the problem, and that we also had to sort of decide in some ways whose experience is the not most important, but who are we prioritizing with this. And we realized that, we were first looking at the problem very much from the perspective of being researchers, and we needed to shift to thinking about it from the perspective of the frontline clinicians and particularly the frontline nursing staff. And when we did, our intervention, the solution completely changed. And so, I'll be happy to talk more about that, but I just wanted to echo this slide is critical. And, knowing, and we actually wound up terminating our first intervention relatively early. And it really came down to having the right sensors in place. And then figuring out that we were approaching this from a very research-centric, physician-centric perspective. And so had to really change the way that we were conceiving of delirium in that way.
Those are very good points. And that, especially with the development of our teams that were supporting this work, it was a lot of work to get people on the same page. And we just had to keep reiterating this. We really need to look through that lens of what is important for that frontline coworker and what is important for the patient. Because we even would hear, this isn't feasible. And it's, well, why isn't it feasible? And every time we'd ask why, we'd come up with a workaround. A solution is to know, well, we could do this. Is this what's best for the patient? Then we need to find a way. So it is, you have to stay strong and stay true to what you're, passionate about, being that problem, not the solution, and just be flexible in your solution as it's developing. This is just an overview. Now, when I look at this timeline, as I told Heidi, I think anything but Agile. But this is just a simple overview of the work that went into our project. Because we had already rolled out Delirium work in so many areas, we wanted to make sure that we had a thorough process in place. In the past, we had seen bits and components rolled out, such as, we had a Delirium screen, but there wasn't really a process for what happened when somebody screened positive. And in doing that, it kind of minimized the meaning that the nurse was taking away from it. And so completing the screen didn't become as valuable to them. So we went ahead and we had educational briefs that we introduced to nursing well before we started this project. We were trying to prime them that this is what's coming. These are the components. This is the why behind it. So we did that for several months before we started our education in March of 2019. We actually did a 2-hour-long educational component with screening practice for every one of our nurses. It was a lot of work put in place, but we had discovered that in prior rollouts, what they had done was computer learning. It was very dry, very just clicking through presentation slides versus that interactive component. So we put together thorough education. We actually recorded our own delirium and mock delirium videos and had them screen the patient with us. We went through and recorded different RAS levels, what that would look like on a patient, and tried to really make it a comprehensive training. And we also did a pre and post test to demonstrate that the nurses, had retained information. That's why we did the post test several months out. I will say on this slide, you'll notice that the dashboard did not come until months after implementation. That was one of those unfortunate pieces that occurred. So we had to do a lot of monitoring up front until we had that dashboard in place. The dashboard actually shows us patients with likely delirium, Our RAS scores are embedded in our nurse overview screen. That way we have a quick view of all the patients on the unit. And then it also pulls in the pieces to whether the patient has a care plan and it's been documented on. So we're trying to keep that right up front and visible for nursing, but then also for ourselves, we were rounding. As far as localizing the minimal viable solution, in order to do that, this is where the task force was really beneficial. The task force, we created a mission and vision, and then they kind of provided that support, if you will, to our other committees. So we included our community hospitals, our post-acute areas, intensive care, and then medical surgical. And like we've touched on, the more hands in the pot, the more complicated it can get. But we did get a wealth of expertise from all of these individuals. It just took time for us to really focus on that benefit to the nurse and to the patient as well. And then we were able to solidify our plan and move forward. So here's just kind of an overview of our intervention. This, as I said, was a very large project. Immediately, our nurses recognized that in order to answer feature 1 on the CAM screening, they needed to know the patient's baseline. And what I was finding is we were asking what a baseline, the patient's baseline was, and the nurse was basically using the GCS and saying, well, they're alert and oriented ×4. And so my question to them became, can you have dementia and be alert and oriented ×4 at the time of the assessment? Is that really a true picture of the patient's baseline? We also kind of had a misunderstanding of what baseline meant. You know, that's prior to hospitalization, prior to that illness that brought them in. So that's where we built that in to our screening. That way nursing had that information right in front of them at the time. Prevention, we know, is always key to delirium. This one was a struggle because we really wanted to capture those preventative pieces. We don't want to just screen for delirium and identify it. We want to prevent it. And when we had asked nurses how we could handle this, their response was, if we don't screen, it's not going to be within our awareness, which really surprised me that they wanted another screening tool. But that was the consensus, and we built in then our preventative strategies within our general nursing care plan so that every patient has those. And then especially if the patient does screen positive, then there's a care plan that is automatically added for these patients. So we routinely screen all of our adult patients, inpatients, in our critical and non-critical care areas. And then to kind of balance out the outcomes that we were seeing, we wanted to make sure that we had that care plan and especially the order set. So our prior order set was very nurse driven. We ended up removing a lot of those items and putting them in a care plan. And when we did that, we essentially had no order set. So we created an order set. We actually included medication dosages for patients that were greater than 65 and less than 65. So we had both those covered. Then we made sure to include components related to medications, obviously, pharmacy consults, all those different pieces, but we really struggled with the medication component because we know medications are something that we should be using if the patient is a threat to themselves or others. We don't want to just put more psychotropics on board that potentially cause delirium just because the patient has delirium. So what we did is we structured our choices within the order set from those least harmful meds to all the way at the bottom, including Haldol, because we know that there are some unintended consequences that can occur with that medication. And that seems to have helped because we do not see a high utilization of Haldol. And it was something as simple as, are they really going to scroll to the bottom of that order set to find that order? If it's needed, it's there. However, we're trying to redirect them to other meds first. The other piece we included was making sure that there's a comment in there for nursing to try to avoid benzos. That way the patients are not getting out of hand for delirium because we were seeing that occur randomly. So having that in there provided that of reminder for both nursing and the physicians as well. And then of course we have a comment in there related to alcohol withdrawal. That way they know that that's an exception. And then making sure that our patients and family were educated was important as well. So we did create an educational material that we provide to them. That way they have that information and feel that they are able to come to the nurse and discuss the different components with them as well. Looking at our implementation strategy, this was my favorite part. I love to pick things apart and come up with a process to make things sustainable and then also meaningful for nursing. So we did a lot of background work on this. I'd say one of the biggest pieces was considering our messenger. So looking at those components of behavioral economics. So what are the nurses' biases? Who is going to be that appropriate messenger to share this information? I know when it came to leadership level, I was often the messenger. It was kind of a different story that was told, but when it came to the frontline coworkers, nursing led the way all the way. They presented the information at all those meetings, the rationale, and then also helped with the training process. That way it was one of their peers that was providing that education, plus helping us to come up with that educational plan and identify some barriers that we were not necessarily aware of. Structuring complex choices is also important. We definitely wanted to make sure that this was a very feasible process, that it was, you know, almost an automatic process as they were walking through this. So we definitely included those pieces in the order set and then also in the screening tool itself. Priming we did with our educational tidbits that we had sent out over the months prior. And then those feedback loops we all know are important. And so we had asked nursing, what's going to work for you? How do you want to hear the outcomes? And what they told us is we get tired of numbers. We hear numbers all the time. That doesn't really mean, they don't really mean a lot. We don't get that takeaway from the numbers. We want to hear what the actionable components are that we can address. And I was happy to hear that. We do share, of course, at our leadership level, we have data that is shared routinely on Delirium and all the associated measures. But for nursing, we give them more of those takeaway pieces. So if a patient, say, had a negative experience, or maybe there were opportunities, we build stories from that and share that with nursing. And that seems to carry a lot further with them. But then we also make sure that we share their overall levels of success. That way they can compare and benchmark themselves to other units throughout the organization as well. So here I thought was a good slide to share. It reminds you of all these components to consider. We've touched on messenger. Incentives are one of those you have to be cautious how you use those and what type of incentives. We like to look at our incentives as that positive patient experience, another patient going home without that delirium experience, instead of how you would typically look at incentives. Norms, my takeaway here would be, if people can find a way to do something, find a shortcut, we'll say, around something, others are going to follow that pattern. And so we have discovered the way we set up our delirium screen, we wanted to make it as simple as possible. So if they're feature 1 negative, they did not have to go on and complete the rest of the assessment. We thought that was a great process. It minimized the amount of charting in the EMR. But what we realized is if they just chart it's negative, now they're not doing the rest of that assessment. And we know that those other 3 components can be even more valuable than having noticed that change from baseline. So that's one of those things that became a norm. I think that was something that occurred as a result of COVID. We had a lot of documentation changes, so shortcuts were found, unfortunately. So that was kind of a negative norm that was found, and we're currently doing some work to change that flow. That way we don't continue to encounter that. Making it salient is definitely important. I think with a lot of conversation and continued communication about delirium, it's become something that's very important throughout our organization. So I feel like we're doing a good job of that. Same with priming. If we identify any kind of ongoing trends related to our delirium process, we make sure that we're getting that subtle message out there. That way, hopefully we can see that impact and change. I'm not going to go through the rest of these, but I wanted you guys to have these. I think this was very valuable for our team, and we actually sat down and went through each of these and considered what we could do to help mitigate some of these. And I know I mentioned the word nudge. I remember I did the short course to Agile implementation, and one of the first things I learned was a nudge. And I kept, throughout my time in healthcare, I've wondered, what is the polite way of saying you're encouraging a behavior, you know? And when I heard the term nudge, I thought this is perfect. So it's that choice architecture that's kind of leveraging human tendency in information processing, and then that resulting behavior. So how could we kind of nudge some of these choices along? And this is where our nurses really enjoyed it. They sat down and came up with different strategies, and we've used this in multiple projects as far as what we can do to kind of nudge our nurses in the right direction. And I'm happy to say that that word is used routinely throughout our organization now. Now, looking at this step here, making sure that we're monitoring that performance. This is a slide I had shared previously. So what we were doing is looking at our overall incidence of delirium. We have a monthly report and one that we can run ad hoc. As we know, though, when it comes to coding, this is going to be that delayed data. It's not nearly as actionable because it can take 30 to 45 days to see those codes go in place and have that data available. It's something that we use from the task force perspective, but definitely not as beneficial probably at the nursing level because there is such a delay in getting the data. We did have a reduction in our cases during this first phase where we had implemented, as you can see here, and we've had a slight increase in our overall average cases per month, predominantly in 2020, looking at April, June, and September, which we also seen increases in other things such as our falls. And I think a lot of that was related to our spikes in COVID cases. So definitely some opportunity there. I know with our length of stay, it had an impact as well. Looking at our length of stay, we did have initially a reduction in our length of stay pre and post implementation. I know again, though, that there were those months in 2020 where we did see that increase, and a lot of it, we're still analyzing the data, comes down to those that were diagnosed with COVID. That length of stay, we had anywhere from 0 to 73 days in 2020, especially during those heavy months. Now, looking at performance outside of that area, you definitely want to monitor the overall system. So how is this functioning at that large scale level? One of the components that we had done is we definitely wanted to make sure that we had that pre and post test. But within the post test, we tried to simplify the process for nursing. So we actually made the post test include a screening checkoff. We used, again, videos that we had recorded of delirium screening and had the nurse complete the screening process based on that. And we were able to then use that as a competency for the year. So it was kind of a 2-for-1. If they completed that post test, then they were going to have that competency completed. We did see, and this is just overall, it was a 22 item pre-test. We did see an improvement in the scores anywhere from that minor 0.3 all the way to 50.2% an improvement. And we did have about 800 nurses that had completed that. The additional outcomes, this I know we touched on, I call them balance metrics, but kind of those unintended consequences. There was that concern that rolling this out from our ICU to our med-surg areas, we were going to see a huge change in our incidence. Well, we didn't see that, which I'm very happy to say. We also did not, fortunately, see an increase in our Haldol utilization. That was another one of those concerns that we were going to see a sudden rise in that because we were attaching an order set to this diagnosis. And then looking at consults, our consults were only down, we only had half which really wouldn't exist in the world of consults, fewer per month, but I can tell you that our consults have continued to trend down. And that would be with regards to psych and neuropsych. And I am very glad to see that, because routinely it was the same nursing measures versus kind of that medical dive into what was causing this patient's delirium. The takeaways that I definitely like to share is leverage your EMR. If in doubt as to whether something is possible, go to the source. You know, we were told that certain components were not feasible, and lo and behold, they were. So we actually have been able to integrate our care plans into our screening in areas of the EMR, which minimizes that need to bounce between the chart and then the care plan, which are separate at our organization. I think multimodal education is so important when it comes to delirium. We know that identifying it is very challenging. So definitely consider those pieces, because re-education is not going to get you anywhere if they're not getting that fundamental component of delirium and what that screening process should look like. And then nursing involvement. We had nurses involved at every level of this, from initiation to completion. They were there for part of the design, the workflow, and the implementation, which, as you can imagine, 2 hours of screening for every nurse throughout our system took us 2 months. But with them signing up to provide that, we made sure that we did some training with them to make sure they understood screening. They were able to go out and be that champion and assist us in that process. And without them, we would have never completed that process for sure. And then looking at your outcomes, when possible, you definitely want that monitoring to be available pretty quick after your implementation, not have that lag like we did, but making sure that you're going to have something there that at least gives those actionable components. Having incidence and length of stay, as I mentioned, doesn't really serve as a very strong message for nursing. So that's where we embedded that RAS score in the nursing overview screen. And then, as you can see on the bottom of this slide, making sure that we're addressing the patients that are missing their assessment, the patients that likely have delirium and don't have a care plan. And then, especially for myself, I like to look at the ones that likely have delirium. So those would be the patients that screen positive that we need to get in and round on. And this provides us that timely ability to do so. And then don't forget about resource allocation. We are all one person, and we have big dreams, and we want to see, you know, the end of delirium. We want to see all these improvements, but it takes a team to make these changes. So just make sure that you have a well-developed team and support throughout the organization as well. And then this is just the last step here. So this is developing your minimal standardized operating procedure. My takeaway from this slide is always to standardize the minimum, not the maximum. So we developed an overview. This is what it looks like for our patients who are being screened. And then this is what it looks like for patients who have screened positive. And then we recognize that what works in one unit is not necessarily going to work in the others. So for example, in our palliative care unit, our hospice unit, this was not going to be a feasible plan, so we had to allow for some fluctuation. So make sure you document. I believe that our final plan for delirium was about 33 pages long. The reason for that is because we wanted to know how we got to each decision that we did. That way we'd be able to communicate and tell that story in the future. And I think that was something that I definitely still do on projects, because it gives you that ability to say why each step was made and to share, especially if you have opportunities or you see failure in your project. It really gives you that clear lens to look through. Want me to pause here? I have no clue what time it is.
Yeah, that was excellent. It is 2:47 my time, so we have about 13 minutes left. And I know that Alistair put a question in, and I know Kate would like to share her experience.
Yes, please do.
So I'll just read Alistair's question real quick. What is the prevalence of delirium in your population as measured by your process?
Let me pull it up here. Sorry, I have it written down here. right now, how we look at our delirium case, because we've had a lot of trouble with identifying how to capture this from the unit level. I don't know why we have such an issue with that. So we look at our overall incidence, and right now for 2020, we average about 66 cases of delirium a month, where prior we were looking at upper 70s, but that's just kind of an overall number. And we're still working with all of our different data support individuals to come up with a better measure, because I thought it would be a straightforward process, but because of coding and some of the challenges with pulling that and attributing it to the different units, we have yet to develop the clear picture that we would like to see. So I know that's not a good answer, but that's been one of our largest challenges throughout.
Lindy, what's your monthly admission number
Oh, goodness.
in general? If you have to, I know you're a big hospital, so.
We have, well, just for PRMC, we have, I'd say we're probably at about 1,000 beds, but that's a very rough estimate.
So 1,000 bed.
1,000 beds.
So 30,000 admit. Technically, 5,000 admission. You think a month?
How about you let Kate answer and let me look at my numbers so I'm not just spouting off. I like that. Give me just a second.
I can answer. You know, my answer is actually caught up in how we ultimately, you know, terminated our initial process and then reconfigured. So we started our delirium initiative as part of a perioperative initiative that is ongoing. And our first thought was, you know, let's get onto the surgical floors, let's really get a good capture of what's happening with delirium in this space. And what we found is that there was an extremely, there were strong differences in the perception of delirium as a problem and what the potential solutions could be depending on who we spoke with. So I think going back to that question of, you know, confirming demand, we definitely had a sense of demand from the health system leadership because there'd been a new understanding of how closely delirium aligned with length of stay. And that for people whose delirium was recognized, we were looking at double the length of stay as those who were not developing delirium. And so there is a real interest in targeting delirium as an intervention. Coupled with that, though, was a lack of recognition at how prevalent it was. And that was a giant question mark for us because we knew, you know, much to Lindy's point of, is this encephalopathy? Is this delirium? How is it being coded? Is it being recognized? As a quaternary academic medical center, a lot of the patients who we were seeing in certain subsets of our mission were people who had not previously received care with us. So it was hard for several of our clinicians to get a sense of what someone's baseline had been if they had never engaged with our health system until they had a trauma or, you know, an organ rupture or whatever the reason was that they were being admitted. So we started our initiative in the surgical floors, and our interviews with frontline nurses were very eye-opening. You know, the nursing staff was really overwhelmed, and there was a fair amount of burnout. And one of the things we were able to do was to align our mission by linking burnout with caring for patients with delirium and recognizing, you know, this is a population that's very difficult to care for. And something that really has stayed with me is the sense of moral injury that the nurses spoke to when they were taking care of patients with delirium, because, you know, they'd have somebody who is incredibly medically complex, who had needs, whether that was pain needs or illness needs or what have you, and then they'd have someone with delirium who also had needs and may have some of those same medical complexities, but they were so torn at who do they prioritize in this situation. The other thing that came out as a theme, and I've encouraged my nursing colleague who gathered these data to publish this because I think it was very powerful. The other theme that emerged was sort of the sense of learned helplessness, that the nursing staff was doing so much to care for patients when they first recognized the delirium. And then they were asking for help when the delirium had already been around for a while. And then they would ask for help. And the resident physicians who were responding nearly universally responded with, well, do good care, like, do good nursing care and it'll get better. And the nurses were saying, no, this is what we've been doing. We're calling you because someone is taking a swing or pulling out a line, and we need chemical restraints or physical restraints. And so there was this really intensive mismatch between the nursing staff and the house staff in what is the understanding of the problem, what is the nature of it, who owns it, and what the appropriate intervention should be. And so at that point, we realized, okay, there's a lot going on here. Let's see if we can focus just on characterizing the problem better. Because what the nursing staff is telling us is that in order to handle this problem, we need something more like what you're describing, Lindy, having another person who can come through. Is there a consult service? Is there some more effort that we can bring to this? And starting out, we were not resourced to do that kind of intervention. So we started out with a goal of characterizing the problem. What we found is we initiated BCAM screening. It was very interesting because what soon became apparent is that the nursing staff already had so much on their plates that asking them to do another assessment was a bridge too far. And so for us, and I'm saying this is just for us, specifically for the surgical units, this was not effective. And fortunately, we had started with a sensor where we said, okay, if this is adding to nurses' burden, so we asked questions about burnout before, and we had questions about burnout after. And so that was a no-go. If we're adding to burnout, then this is done. Our next was, if we're not doing this accurately, then it's not worth doing. And so we had a nurse practitioner colleague who performed a CAM, and essentially we did little spot checks. And so for about 80 patients, she performed a long version confusion assessment method and compared that to a BCAM that another colleague who is trained would do, and then compared that to the nurse's bedside BCAM. So we basically had a 2-point comparison where there was the bedside nurse BCAM, I'm sorry, I misspoke, the NP did a BCAM, and we knew that she was formally trained on that. And then we actually asked our geriatrics consult team, because they do trauma consults, and we asked them, either the NP or the geriatrician, to do a long form CAM, and that was our gold standard. And this manuscript is currently in preparation, so we're getting there. But this answers the question about rate, Alistair. So for the long CAM, we had a rate of about 15% of our surgical inpatients over the age of 65 were developing delirium. The BCAM done by the NP came back with a rate of about 10%, which 10-11%, it was in line with what you usually see as the drop off in sensitivity with a BCAM. And then what we found by the bedside nurses, it was less than 1%. And so at that point, we realized that this was not an accurate tool, and not because the tool itself wasn't accurate, but because, while everyone was incredibly kind, I live in North Carolina, which is the center of niceness on planet Earth. No one was going to say, I can't do this, or this is too much. But what they were doing is they were screening. And when our NP, LaShonda, would go and do screening with them at bedside, the screening was accurate. But we talked to a couple of nurses later and said, you know, it seems like this is a bit much. This is too much. Can you tell me what you're thinking about this? That was the BCAM, Alistair, the Brief Confusion Assessment Method. And when done correctly, it was it was picking up the majority of the time. The correlation between that and the long form CAM was quite high. But when the bedside nurses were recording it in the EHR, they would probably do it correctly, and then record it as negative because they were documenting so much. They would get to the point of documentation and they're like, wait, is that person actually delirious or not? And it just wasn't an accurate tool. So, you know, there was a little bit of Sturm und Drang because we had, you know, set up this whole plan that we thought was a great solution, right? So we had the BCAM that was linked to a BPA, and that was linked to an order set, and you know, we had done all of this education, and it just really didn't, work. What we found though in the meantime is that the order set had taken off, and the order set was not linked. Very low delirium detection. And the order set had taken off. And so residents who had rotated on their surgery rotation, residents who had rotated on their medicine consult rotation had found this order set somehow. And all over the hospital, we wound up having hundreds of uses of this standardized order set for delirium management that had not been triggered by a BCAM. So that caused us to take a giant step back. We shut down the nursing screening program and got a lot of kudos from the nursing team because apparently that was the first time that anyone had ever de-implemented anything in like 10 years. So they basically, what's great about that is that they basically came back to us and said, the next time you have something, we will do it for you because you stopped it when it wasn't working last time. But we decided at that point that the nursing staff was overburdened. And, you know, I won't go into the details, but like that was shortly before COVID, and then COVID started and we're like, you know what? No, our nurses are stressed. This is not the level that we need to focus on. So we retooled the delirium order set, and we've had the following actions that have come out of that experience. We decided to hit pause on the surgical space. The MDs, they were often using, And so we decided that our drive to know the number was being driven by a desire to show that it worked for us, that was an ego space for us as researchers and for us as leading the team, that we wanted to be able to say, this is how much there was and this is how much there is. And so we took a step back and said, okay, well, if we're thinking about the good of the patients and the good of the system and the good of the frontline clinicians, what is better to do? And what we realized is that there was a pervasive belief that this was inevitable. The delirium was inevitable for certain people. So how can we reframe that belief? And so what we did is we moved the detection upstream into the ICUs. Because that's another thing nurses were telling us, is that they really felt that the ICU problem, the delirium problem, was starting in the ICU. And since so many people flow from the ICU to the floors, it was better for us to start the documentation process there and have, as you were pointing out, Lindy, a record of the baseline mental status in the ICU setting. So that's thing number one. We then moved the standardization over to our ACE unit, both at our main hospital and at our community hospital, and found that the BCAM rates and the BCAM success was much higher. So, you know, rates were coming back of 20%, 30% delirium in our ACE unit, both here and at our community hospital. And so that was working much more the way that we thought it would, which also helped us understand that what works in one community, you know, it's a complex adaptive network, right? And so, you know, what was working in one set of nodes was not working in another set of nodes. And so the ACE units are really doing great with this. And in the medical ICU, the medical space, that was really working. The next thing that we realized was that it's done Q12 on the units that we were doing it. And our shifts are predominantly 12-hour shifts. So then we retooled and said, okay, well, here's another thing. There's not as much of a drive in the surgical space, partially because there's not a sense of how this affects reimbursement or how this affects length of stay. So let's take a step back and also say, you know, what's happening. And we got into the same question about encephalopathy and delirium. And so one of the outcomes of this is that we formed a task force on documentation and billing. And so in order to determine what counts as encephalopathy and what counts as delirium, apparently Medicare allows each institution to come up with its own reasonable evidence-based definition. And so that's been very productive because it brought experts in neurology, psychiatry, geriatrics, ICU care to the table, along with nursing leadership to say, okay, how are we defining this? How are we recording it? And so then that sort of shifted the value of identifying delirium and improved the value of it. Because if we can say, you know, there are forms of encephalopathy and delirium that are the same, and we can code encephalopathy and have that appreciated and valued, then that gives us the opportunity to all be on the same page with the value of identifying this as a problem. And there's so much stigma. That was the other thing that came out with the nursing staff and the physicians, is that saying people had delirium, they felt almost like they were insulting the patient when they said that. And a frequent theme was, well, I said that this was the same as baseline because I wanted to give them the benefit of the doubt. It's like, well, I mean, if he can't do what he needs to do, then that's not good. So what we're doing for the surgical floors is we revised the admission templates, and now we have prevention techniques that have been pulled from that order set that are now part of the admission technique for admission templates for everyone who's coming in for surgery. And we are starting a perioperative care pathway within geriatrics, where we will be seeing all frail and pre-frail older adults preoperatively who will have an inpatient stay. And that gives us the opportunity to document a solid cognitive history beforehand. And so I anticipate we'll be in a different place when we come back to do delirium screening on the surgical floors. But so our story is one of adaptation. It's one of you know, terminating a process and resuming, and really recognizing what was the data that we needed in order to come back to this space. So, you know, viewing it rather than as, you know, the narrow lens of delirium in the surgical space, by taking several steps back and saying, okay, what's the issue for us as a health system? We're able to say, okay, this isn't the right place for us to be starting right now. So that's the short version. I hope to be able to share some of that with you, but not bad for a frailty person, just to throw that out there. It's, you know, I am a geriatrician, but you know, this is not as much my wheelhouse, but you know, we really found that the prevalence of delirium in our frail folks. We have an EMR-based frailty index that's a passive digital marker for frailty that a colleague and I have adapted from work in the UK and Ken Rockwood's work. And so that's live in our EMR now. So that's another opportunity, is that we are using that to determine a higher risk population so that we can screen a higher risk population. Now I'll stop babbling, but that's been my experience.
Wow, well, thank you for sharing, both of you. And I know we're over on time, but if anybody wants to ask any questions, I don't even have anywhere to go, so please ask away.
Yeah, I mean, I think it's an extraordinary, you know, sorry I arrived a bit late because I was just driving home, but
extraordinary
efforts. I want to almost, I hope this is being recorded. Like, I want to sort of go like an Old Testament scholar through every single line of every slide and everything you've said to try and learn, because I don't want to reinvent the wheel, you know, and I want to make sure that and a lot of it is familiar to me, you know, the issues around well, detection, all these different things. The order, we don't really have order sets in the UK as much, you know. It's not as formal as that, you know, but like the actions following a positive screen is a massive problem as well. Like what's the point in putting all that effort in if the doctors just ignore it? But I think the context in the UK is maybe a little bit different, because the last few years have seen a huge upsurge in interest in delirium, and it's just normal now just to talk about it and for it to be part of day-to-day work. Like in the hip fracture audit, which is all hip fracture patients in the whole of the UK, they all get delirium screening, and a quarter of them are positive, and it's 95% completion. So that's sort of just been put in as a mandate, and so hospitals have to do it. But yeah, I really want to learn about and I think also that the solution is less delirium, isn't it? Less suffering. And I absolutely love that organizing principle of go for the fall in love with the problem rather than sort of make a solution that's you're struggling. Like for the 4AT, which is the UK's sort of #1 tool, but like it doesn't work as a monitoring tool. It's because it's got cognitive testing built in. People just don't like doing once a year backwards, twice a day for 5 days. And I don't know whether that's the case with the BCAM, with the tests that are built into the BCAM, like the same repetitive questions, because we've found the nurses hate that and the patients hate it, especially the patients who aren't unwell, and that it creates an aversion to the whole thing. So the UK has moved to a kind of two processes. One is an episodic tool like 4AT, but on the wards, we're trying to implement NEWS 2, which is National Early Warning Score. So it goes, there's levels of alertness from unconscious, response to pain, response to verbal stimulus. And there's a new role, which is new confusion. And then there's alert at the top. And it's supposed to be tied to the SQUID. So it's a single question. And the nurse is supposed to just ask that one question: is the patient more drowsy or confused than they were before? That's it. There's no direct cognitive testing involved. It's not really been tested properly, but it's meant to be light touch, and it's basically to summarize all these old tools like the DOS or the New Desk, which were long and sort of did it at the end of every shift. But just to harness the nurse's knowledge of the patient and not to make them do interviews with patients, repetitive interviews, because I think tools like the 4AT, the BCAM, which involve direct testing and cognition, can be done maybe, I think, a few times, like pre-op, post-op for 2 or 3 days, or if people have got delirium. That's my experience, but I'm interested to hear. But I think I've tried to split those up between the observational, inpatient monitoring for new delirium process versus the transitions of care that have come down from the ICU or they've just been admitted. Then they need a beefier tool that tells you yes or no, more or less. But it's not that we've got that right. I mean, we're learning all the time as well. And I'm intensely interested in implementation because the delirium field is full of validation studies, but hardly any implementation studies. So this is exactly the kind of work we need to have out there, and I mentioned in the chat the Rohatgate and Friedman studies that just came out in the last 2 years. I don't know if you know those studies. Rohatgate was in Stanford, 105,000 patients over 5 years. Think of the person hours involved in that, and lots of lessons from there too. And what seems to be the case is that the order sets do work, but that the detection has to be in place to trigger those properly, as you seem to be saying. Anyway, I'll stop talking now because I'm just reflecting now. But I always say more implementation studies. So this is like amazing to hear, and I really want to go back, and because we're about to do a big strategy, we're behind you a little bit in a formal strategy locally, just to sort of implement a lot of these lessons in my healthcare system, which is 2 hospitals of total of about 1,700 beds. So it's a big job. Thank you.
I did just have one quick question. Was your intention when you initiated this project, was your intent for it to be a system-wide project, or how did you make the decision to go, and forgive me if you talked about this, but you started inpatient and then you went to operative, or how did that jump happen? Am I asking the question clearly?
Is that for me or for Lindy?
Either.
So I can answer. So our intention was to start perioperative because we had perceived that as being cleaner. And what I mean by that is that there was a desire to link this in sort of a learning health system way also to our cognitive research. So, what we were thinking was that there was a clear, insult, right? That the operative intervention, anesthesia, the trauma of surgery, like that this was an insult, and that, essentially, if we had people who were more likely cognitively more robust, so if you're sort of like in a way, like, arrows going, like if somebody is more, is more cognitively robust, they're going to need a bigger insult to develop delirium, whereas if they're less cognitively robust, they're going to need a smaller insult for delirium, right? So what we had thought was, it's a little harder to, suss out on the medical floors. How long has this been going on? Is this an acute change? Things like that. Has somebody, subacute, had confusion for a while before coming in? At least as a geriatrician, that's often what I see. And people will say, yeah, mom started kind of shifting a few days ago, things like that. Whereas in surgery, typically people, we're talking about people who had the capacity to sign consent a couple days ago, and now they're altered. So we thought there, our hypothesis was that there would be more uptake in this space where there was a sudden perceived change. Also, we were starting to do some frailty work in that space as well, so we thought we'd kind of go along with all of it. What we found, though, was that we needed to make it a health system-wide approach, and that was both because it's a pervasive problem across the health system, but also the nature of our staffing is such that our med-surg nurses go all over the place. And so doing an intervention that was targeting surgical nurses really wasn't feasible because, a significant portion of those nurses were also working on the medical floors, and that churn meant that we needed to take a step back and say, okay, are we confident enough in this training and in this situation that we want to roll this across an entire system of staff? And so I'll let Lindy answer that. But we started with surgery and then backed off from it and then are coming back to it. And so what we found is that, it's just very difficult for nurses who are focused on chest tubes and wounds, and, many of them have rapid discharges. You've got people who are coming in who have 24-hour stays, 36-hour stays. On the medical services, there just was a little bit more time and space to think about delirium. And we've been able to try out some interventions that then we can circle back to the surgical space with that increased rapidity and time pressure, and sort of knowing where to start. We were wrong, and we figured that out quickly, and we were able to pull the plug before we did too much interpersonal damage.
Yeah, and our story is kind of similar as well. We recognize that our nurses frequently travel to different areas to work. The one challenge that really occurred, we did not set out with the desire to make this as large of a project as it was, but unfortunately with our EMR, if we were going to include the delirium screen in our nursing assessment, it was going to roll out to all of our areas. And that was something that we did not anticipate. So we did had a lot of conversation among our task force and our community hospitals, and the decision was made that it was something they wanted to see throughout the system. So it did have an impact. And we've had, as has been shared, some of these same barriers as well that we will continue to adapt to. And along the way, I'm sure that there'll be new learning opportunities, but it was definitely a far bigger rollout than anticipated when it was first started.
Other questions? I know we're like 16 minutes over, as has happened with our other live presentations too. So truly appreciate Lindy and Kate. We set this up like on Monday, and I like completely appreciate your ability to be agile and get this together, and for everyone for joining. So this will be available on YouTube. I will tweet out the link, and I'll also email it out so you can distribute it. And thank you all so much for joining today.
Alistair,